Hi, I'm Doug Pleskow. I'm the co-director of endoscopy at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. We started doing radiofrequency ablation for Barrett's esophagus about 7 years ago. This was done in patients with non-dysplastic Barrett's, and we were very excited about the results. We then began doing RFA for patients who had dysplastic Barrett's and had excellent results with that as well. The pivotal paper that came out in the New England Journal in 2009 then demonstrated excellent results for patients with high-grade dysplasia as well as low-grade dysplasia. We began enrolling patients into our cohort of patients at the Beth Israel Deaconess Medical Center. Our results were very good and similar to those patients that were published in this study in the New England Journal of Medicine. But we also noticed that there was some failures of patients in this cohort of patients. We wanted to continue with endoscopic therapy because many of our patients either, number one, did not want to have surgery, or number two, were not surgical candidates. They asked us for additional types of therapy that we could utilize. We then began exploring the use of cryotherapy for our patients with Barrett's esophagus. And we treated these patients as failures for radiofrequency ablation, or actually as primary treatment options for patients who had nodular Barrett's esophagus or patients who had intramucosal cancers. Cryotherapy is another valuable tool in our toolbox for the treatment of Barrett's esophagus. It requires liquid nitrogen at this point in time, which is instilled through a catheter through an endoscope. Due to the expansion of gas from the liquid nitrogen, we do need to have a venting tube at this point in time. There have been some technical advancements over the past several years which make this much easier to use. Technically, this is done, an area is half circumference of the esophagus is frozen for 20 seconds, and then we let this thaw and then we freeze again. We go on to the second half circumference of the esophagus, and we can treat 3 centimeters of esophagus at any one point in time. Now, in order to get to that freeze, what our practice has been at the Beth Israel Deaconess Medical Center is to ensure an adequate hard freeze prior to counting the treatment of 20 seconds. We want to make sure that there is complete freezing of the treated segment, and then we continue our freeze for 20 seconds. We also need to have a complete thaw before we instill the second treatment session. I think it's with this particular technique that we get our excellent results, because we get adequate freezing and then a thaw cycle with another freezing cycle. This study was done as a retrospective analysis of all of our patients who had Barrett's esophagus with dysplasia over a 7-year period between 2006 and 2013. We initially evaluated all of our patients who had undergone radiofrequency ablation for Barrett's esophagus with dysplasia. We had 121 patients who were evaluated, and a majority of those patients achieved complete remission of their dysplasia. However, there were several patients who did not get complete remission of their dysplasia with radiofrequency ablation. We had then offered these patients cryotherapy, and we analyzed that subset of our patients for treatment with cryotherapy. The numbers that we had were that there were 30 out of the 121 patients who we had treated at our center between those years who had persistent dysplasia after radiofrequency ablation. Of those patients, 11 had no cryotherapy and went on to other alternatives, either further radiofrequency ablation, esophagectomy, or radiation therapy for cancer. 19 patients who had cryotherapy were entered into the study. There were 2 other patients who had ongoing treatment with radiofrequency ablation that were then included in our cryotherapy group of patients. Of the 21 patients that we had to evaluate, 16 were available for follow-up. We did not have follow-up for 5 of the patients. Of the 16 that were available for follow-up, 12 of these patients had complete eradication of their dysplasia. 4 did not have complete eradication of the dysplasia and had some ongoing dysplasia after cryotherapy. Overall, adverse events for the study were very rare. of the 21 patients who were evaluated, there was 3 patients who had new onset dysphagia requiring dilation. These patients all responded within 1 or 2 dilations with resolution of this dysphagia. We also had 2 patients who had developed ulcers that responded well to high-dose proton pump inhibitor therapy. We were then able to go on to complete treatment with them. We had 1 patient who also developed a tear during cryotherapy. Barium esophagram demonstrated a localized perforation, which was managed medically, and the patient did well, and we were able to go with repeat cryotherapy with eradication of the dysplasia. So in summary, endoscopic treatment for Barrett's esophagus has been demonstrated to be a very effective treatment. We have in our armamentarium radiofrequency ablation, cryotherapy, and EMR as our standards. Radiofrequency ablation is an excellent endoscopic treatment with terrific results, as evidenced by the pivotal study in the New England Journal of Medicine. However, in that study, as well as our own experience, we do see failures for treatment for dysplasia. Many of our patients want to continue with endoscopic therapy for this because they don't want to have surgery, or number 2, they're not good surgical candidates. Cryotherapy is an excellent option for this cohort of patients. The next steps, I believe, are to start a multi-center prospective trial for the evaluation of cryotherapy after radiofrequency ablation. I think we need to get more numbers at many more centers to see if we can reproduce the results that we've achieved here. In addition, what we need to do is to find what factors may predict success for radiofrequency ablation and what factors may predict success for cryotherapy. If we can predict these things pre-treatment, we might better get them to a point where we can give them one specific therapy, whether it's radiofrequency ablation or cryotherapy. This may take some time, looking at multiple factors, demographics, the characteristics of the Barrett's, absence or presence of hiatal hernia, as we and others have described. So I think that's very important. There are probably some genetic features as well that may need to be evaluated that may predict success or failure of these specific treatments. In addition, advanced imaging may eventually give us some clue as to which patients may succeed with radiofrequency ablation or cryotherapy. So we have many different things that we have to look at in this patient population to evaluate success and failure of treatment. So I'm looking forward to this. I think this is a very exciting time to be involved in treatment of Barrett's esophagus.